Let's take a look at this 72-year-old man with a PSA of 6.44 and a prior biopsy that was negative, no evidence of cancer. You've got a fast spin echo, two-dimensional, T2 in the axial projection, in the sagittal projection on your left, and in the coronal projection on your right. Let's chat about BPH. You know, there are several criteria that have been proposed, but when you're measuring using one of the techniques that we've described in the past, including length times width times height times a certain constant, then 25 cc's is the number, that is the cutoff number that you're going to use. If you want to learn more about measuring, go to our earlier vignettes on BPH. Now, the overall gland size, then, is the major criteria that we use on MRI. So 27 cc's, 30 cc's, mildly enlarged, 80 cc's, moderately to markedly enlarged. So we would measure this and apply the constant to it and give you a number. I'm not going to do that right now because that's just a mechanical maneuver. And then things like histology, stromal or epithelial hyperplasia. The lobar classification of BPH comes into the subsegmental division of the different types of BPH. Now, usually there's stromal and epithelial hyperplasia, but there's also another factor. There's muscular dynamic contraction, which further inhibits the patient's ability to urinate. So let's look at BPH from the standpoint of anatomy, and I like to look at that in the sagittal projection, believe it or not, even though a lot of the PIRADS designations are made off the axial. Now, we're right smack dab in the midline. There are 4 lobar types of BPH. Type 1, the enlargement is anterior, pushes the urethra posterior. That is clearly not happening here. What's happening is the central zone of the central gland in the TZ region, or the posterior-superior quadrant in the sagittal projection of the prostate, is enlarged, pushing the urethra down and forward. Type 3 is when they're balanced. This is as big as that, and the urethra doesn't move. And type 4 would be pedunculated or lobulated extension into or invaginating the urethra, often very difficult to see unless you have high-resolution imaging. So this would be an example of a type 2. Now, in the axial projection, that's a little harder to discern. You might be tipped off to the fact that it's the CZ or central zone or posterior gland that's markedly hypertrophied because there's so much enlargement as you go up to the prostate base. Now, within the prostate are these well-defined hyperintense nodules that have this acinar or glandular look to them. They'll be hypovascular, so that's a good thing. They'll show up very bright on the B0 image, but as you increase the B value, they'll dissipate, which is also a good thing, so a sign that they are not cancer. And you'll also have some solid gray nodules, like this one right here, and they'll also be well marginated. You don't want to see anything that is smushy or gray or charcoal-like that erases this lobular, nodular anatomy within the gland, and you certainly don't want to see anything that crosses the surgical capsule, which is right here, going into the peripheral zone, or crossing the anatomic capsule, which is right here. So in the coronal projection, this type 2 BPH, because it's posterior-superior, really presses up on the bladder. And occasionally, it'll look a little bit like a piece of broccoli or cauliflower. It'll have segments that extend off that are a little bit pedunculated into the bladder. And when that happens, the necks of these pedunculated areas of BPH can get trapped within the bladder and cause problems of their own. So this is a patient that demonstrates really profound elevation of the bladder with marked trigonal thinning right here, which is part of this form of BPH. Now, when you look at the diffusion-weighted images in BPH, you should not see anything that progressively gets brighter. So here's a low B value, B0. Let's blow it up for you. And then let's take something really high. This is a 1500 B value. Let's blow that up. And I could look at the ones in between, and you would see that the bright areas, let's take a bright area if we can find one. Can't really find a good one here. But the bright areas like this one, there's one, and it dissipates progressively as the B value goes up. And that's to be expected because it's not a cancer. And then we've got some intervening b-values, and we'll inspect them serially from B0 to 400 to 800 to 1500 and so on. Let's take a quick look at the contrast enhancement. We've got both dynamic contrast enhancement here, and actually that is not it, that's the b-value. But it's a nice illustration, actually, of what happens to the high signal areas as the b-value goes up. They get lower. Let's see if we can find a dynamic contrast enhanced MRI that's a little bit better to see. I have a delayed one right here. Actually, here's my dynamic. So here's my dynamic contrast enhanced MRI. And you can see the gland pretty much uniformly enhances. The brighter areas remain cold, as we discussed a little bit before. So this is my dynamic, not my delayed. And just to get you oriented, each one of these is a phase. So mask, 10 seconds, 20 seconds, 30 seconds, 40 seconds, 50 seconds, progressive wash in, nothing sticks out by its own, 60, 70, 80, and so on. And you can create as many phases as you want. This is DCE MRI. And then finally, the last part of the exam is the ADC map. Here we are with our ADC map looking for areas of overwhelming low signal intensity within the peripheral zone especially, also in the central zone, although this criteria more important in the peripheral zone, and we don't see anything in the peripheral zone of the prostate. Yes, that's a little fibrous dot, but it didn't enhance, and it didn't show any high signal characteristics on diffusion-weighted imaging. It is to be ignored. And you can get those from biopsy, from old blood, from fibrous tissue, from it being very firm and desmoplastic, but it's tiny. And generally, our detection for prostate cancer is at about 2 to 3 millimeters is our lower threshold. So this is an example of a PIRADS, of a PIRADS 2, which we'll discuss a little bit later on, but it's an example of a BPH lobar type 2 BPH. Let's move on, shall we?